Hi, it's Dr. Centeno. Sorry I'm running a few minutes late today. Let's see, got an interesting topic today. Basically, a patient over the weekend had sent me a blog post by a gentleman I'd never heard of before that really questioned whether or not chronic CCI and AAI exists. And I thought it was interesting. There were some parts of the blog post that I agreed with. There are other parts of the blog post that I strongly disagreed with. So it's one of those things where it's worth going through. Now, the lecture part here is going to be a little more intense because the blog post is pretty intense and pretty dense. But I'd like to go through it if I could. And then obviously we'll open the floor up to questions here. I just got a new phone, so pardon me if I take a second to check it here. Okay, so long story short is we're going to start by going over this blog post, and I'm going to share the screen here. Let me share the screen. Yeah, it looks like that's working. And now we'll go to what I'm going to be talking about. So again, I'm going to start with this review of this Larsen blog that's critical of symptomatic chronic CCI AAI. And then you can ask questions about that. You can ask questions about anything. Again, for those of you just joining us, there was a blog post that I was alerted to over the weekend that was fairly critical of the concept that CCI and AAI exists at all. And I apologize, I have a new phone, so I'm just trying to make sure I'm not missing anything here. Okay. So we're going to go through that blog post and trying to figure out what this gentleman's talking about. The patient was concerned and wanted me to take a look at it because she was concerned that patients new to this stuff would somehow get misled by the blog post. And there may be some risk of that. So like anything, let's just dissect it and see what's going on here. So this is the blog post. It's on a website called MSK Neurology. I'd never heard of this before. It's written by a guy, I believe, from Scandinavia, right? His name sounds Scandinavian, Kjetil Larsen. And it was an interesting post for sure. He had stated that he wasn't sure he was complete with this blog post yet. It sounds like he's been editing it as he goes. So, but it was an interesting one because some parts of this blog post I agreed with. The patient was very offended by it. And I think reasonably so. There's some very inflammatory things that are said in this blog post. So let's go through this. Again, this is what I read over the weekend. Patient sent this. They were concerned because it really seems to question whether or not anything other than neurosurgical emergency type CCI exists. So let's read a few passages from this blog post that I think will give you some sense of the content, right? This is one passage. There's a growing trend, however, within or at least certain alternative medical communities where patients with normal or virtually normal imaging and with the absence of clinical triggers. Now, what he means by clinical triggers is the ability to, let's say, make yourself pass out by turning your head. That would suggest that lenoaxial or craniocervical instability still end up diagnosed with these relatively sinister diagnoses. Interesting. Let's go on. It is crucial to understand that the general minor instabilities involved in AAI and CCI are not the cause of symptoms. A common but severely ignorant misunderstanding, and again, these aren't my words, these are his, that some clinicians make, the patient cannot be blamed for thinking like this, but the clinician should set it straight, is the notion that mild to moderate ligamentous instabilities makes the neck, or the whole body for that matter, tense up to protect the ligamentous instability, even though there is minimal or no clear MRI findings to support this notion, that this somehow causes all of the patient's symptoms. So again, we're going to continue just for a few minutes here reading some of this. Common arguments for treatment may be claims that although the MRI and even upright MRIs are normal, their own DMX scan is positive, or that the MRI, which was deemed normal by the local hospital, in reality shows signs of ruptured ligaments and that this fits with the patient's symptoms. So again, this is the Larsen blog. And then the one final thing that kind of really pissed me off a little bit, and I'm sure it's obviously going to piss a lot of women off. I have lost the count of the amount of patients, usually terrified women. And again, these are not my words. These are Kjetil Larsen, who wrote this blog post, who have been brutalized by clown-given diagnoses, such as brainstem compromise with zero evidence. And I'm chuckling a little bit because this is much of the blog is written in this hyper-inflammatory language. So it's an interesting blog post for sure. So first thing is, reading the whole blog, and it's very, very dense from a medical standpoint. It should be noted that Larsen kind of focuses much of his ire against surgeons that are fusing the upper cervical spine. However, he saves a few punches for injection-based care, Dmx, and the idea that chronic laxity caused by ligament damage. So the blog was worth addressing because he's kind of questioning whether or not chronic laxity exists, and then whether it should be treated at all outside of anything more than a couple exercises. So who is this guy, Kjetil Larsen? I had never heard of him before. I'd never heard anything about him before. He lists no formal medical education on his LinkedIn page, which, as you know, oftentimes people will put their CV on. His bio states that he had experience basically in computer programming, from what I gathered. And he was injured and began his own research as an effort to help himself. And he decided to quit programming in 2014 and basically got a personal training certificate so that it would be legal for him to basically touch his patients or his clients, is what he wrote on his website. And then he learned how to use diagnostic ultrasound in 2017, mostly looking at Doppler ultrasound, meaning vascular flow. And in the US, that probably wouldn't be permitted. I'm sure about the laws in Norway and then Colombia, where he later cited his clinic. And in 2021, he decided to close his rehab clinic in Colombia and attend medical school. So I assume at this point, he's either a freshman or a sophomore in medical school, something like that. Now realize that that's the beginning here in the US of medical education. So you go through medical school, then you usually go through an internship, and then 3 or 4 years of residency, and then fellowship and subspecialty training and yada, yada, yada. So here in the US, he'd be at the first year of about a 10-year journey in medical education. So Larsen began publishing medical research, and I put that in quotes, in 2018. There really isn't much medical research being published. These are largely opinion pieces and case reports. Now, the good news is I read some of these, and he certainly is trying to think outside the box to connect things that aren't normally connected, like thoracic outlet syndrome and vertebral artery perfusion. And I have to say, I kind of applaud him for giving it a shot, because he doesn't really have any formal medical education, but he seems to read a lot. So I'll certainly give him that. So, the good and the bad about this blog. On the good side, any article that makes patients think twice before diagnosing themselves on Facebook is a great idea, or is a great thing, meaning that I've been as critical about that as anyone, that I see a lot of patients that self-diagnose themselves. I don't think that's appropriate, and I think it can be quite dangerous. So I tend to agree with him there, and think that if people read this article and think twice about whether or not they might have CCI, there may be actually some value in that. So I kind of hope that people read the article and say, maybe I don't have this, or maybe I should try more rehab before going down these more aggressive pathways. However, the blog post has a bunch of inaccuracies, so I thought I'd point those out. So the main concern with my blog, or with this blog, is what I call a false dilemma or dichotomy. So this is basically prevalent in this Larsen blog. So that is a logical fallacy that says there's only two choices when more exists, right? A classic example given is you're either with us or against us. Obviously, there are other possibilities. I don't support you. I don't oppose you. I'm kind of in the middle, or I don't have an opinion, or I don't know who you are. Again, lots of different possibilities. But for argument's sake, what happens is the author kind of condenses all the possibilities into only two choices when more exist. And that's what happens here in the Larsen blog. He uses this false dichotomy for instability, right? That you either only have neurosurgical emergency instability, where your head's falling off and you've got fractures and someone needs to bolt it back on, or you have something that he can fix through rehab exercises. And there's nothing in between those two extremes. So a historical example of that is in the 1990s, orthopedic surgeons were convinced the SI joint didn't move at all. And there was no such thing as chronic SI joint instability. Now, 20-some years later, they've changed their mind, right? Because they're fusing SI joints with wild abandon for that same chronic instability that didn't exist in the 90s, even though we still don't have a good way to image chronic SI joint instability. So shows you how these things change, and how just because instability can be difficult to measure, like SI joints, doesn't mean that it shouldn't be diagnosed or treated. So again, this false dichotomy that he sets up is that there's either severe instability requiring emergency surgery or mild instability due to muscular atrophy, and there's nothing else in between. But in fact, we know from, or at least I know from practicing in this space now for almost 3 decades, that there is such a thing called chronic instability due to ligamentous laxity. It happens lots of places in the body. It happens in the knee. It happens in the hip. It happens in the ankle. It happens in the upper cervical spine. It happens in the SI joint. It happens in the lumbar spine. It's been well described in many of those areas. Now, there's certainly less publication on it in the upper cervical spine, but to try to claim that it doesn't exist there when it exists everywhere else in the body is a little bit naive. And again, I think shows a lack of overall medical education. So Larsen is really big on this concept of jugular outlet syndrome, which is sort of a strange way to describe what I think a lot of people have described well before Larsen. And that is that you can get jugular vein impingement just in front of C1 and C2, and that can also compress cranial nerve 9. And a common assumption is that this happens due to instability, but Larsen believes it's all caused by bad posture, or at least the vast majority of it that doesn't require emergency surgery. So if you fix the posture, that will go away. I mean, listen, we always encourage patients to work on posture and recommend therapies like curve restoration. So I can't disagree with him there at all. The problem is that many people, and he describes some that he's treated as well, are made worse by trying to do this. And those are the patients that generally fall into this instability category, or chronic instability category. So Larsen describes one patient that he treated that didn't get any better with his exercises, but he was convinced didn't have this, and he kind of dug in his heels about it, et cetera, et cetera. And that's generally been our experience with this population. They try active exercises, they try working on their posture, they try improving their neck curve, but it generally only increases their symptoms, not improves the symptoms. So there's something else going on there. And because Larsen's focus is on vascular compression, he believes that in order to have a real CCI diagnosis, you need to have head movement basically cause substantial decrease in vascular flow, whether that's vertebral artery or internal jugular vein. And that's the only way you can get symptoms. Now, obviously, that's not correct. We see all the time that patients have upper cervical facet joint pain and injuries from this instability, and that would be outside of Larsen's educational sphere, obviously, only having a certificate as a personal trainer. So it's not surprising that he doesn't know about all of that, but it is surprising that he takes such a hard line despite not knowing what he doesn't know. And then Larsen is very highly critical of anyone getting fused for CCI or AAI, who again doesn't have that emergency neurosurgery type of injury where there's fractures and the head's hanging off, and that person's got to be fused right away to save their life. And I can't disagree with him that upper neck fusion rates are way too high in this population. So I think that's a valid criticism. And he also advocates that you should stick with large hospitals because they somehow know what's going on here. Again, that one doesn't make sense to me. You know, patients seek out super specialists in CCI because they're getting zero answers from their GPs or large hospitals or the average spine surgeon or the average university hospital. And that's why we see about 70% of upper cervical fusions being performed by just 5 or 6 surgeons worldwide, because they have taken the time to dig into this. Now, do I think there's too many fusions being performed? I do. Having said that, if I were to send any of my patients for surgery, I'd send them to one of those 5 or 6 neurosurgeons who do this a lot, because I wouldn't trust the local hospital to do these procedures or even understand what's wrong with the patient. And he also criticizes using static claviaxial angle, grab oaks, BDI, other measurements such as translational BDI or BAI. And he argues that we need to use lots of things to make this diagnosis. And I can't disagree with that either. That, as we've talked about, we use lots of different parts and pieces to make this diagnosis, not only these measurements. And then I'm going to start wrapping this up and talking about Larsen and DMX. I'm going to read from Larsen here. This is why I have this in quotes. DMX, this is really one, if not the worst offender with massive, and again, Larsen's not a native English speaker here, so I may need to correct some of his grammar, with massive overestimates of craniocervical pathology. I've seen countless reports from DMX centers where the patient, despite having normal or virtually normal conventional imaging, the patient is delivered reports of laughable quality, typically deeming the whole neck as unstable despite the images being virtually normal. So this is an interesting topic because I would agree with some of this and obviously disagree with other parts of it. So on the one hand, we see lots of bad DMXs out there. So we see those bad studies all the time. And that's why we've developed a list of reliable DMX facilities. Part of the studies are bad because that particular provider only has old technology. Part of them are bad because they're not doing the DMX protocol correctly. And I also see these DMX that report way too much, and it freaks patients out, right? This facet gaps or this facet opens when I turn my neck, or I've got a little bit of translational instability in 5-6 that must be awful and causing these sets of symptoms, when in fact both of those are probably normal variants that happen with degenerative instability and probably not causing any of the patient's symptoms. Where I would disagree with Larsen is he doesn't seem to have reviewed this DMX study, which was done not too long ago and discusses basically normal versus abnormal DMX imaging. So what's interesting here is that this study is really a critical one to understand. And let's go into it a little bit. So the problem with neurosurgical measurements are that we only understand what's normal when comparing against patients that require emergency surgery. And you've heard me say that many times. And what that means is that if your head's hanging off and we take some measurements, we know what those look like. But the problem is that the surgeons have not performed those measurements on this population. So they don't really understand how those measurements identify someone with chronic CCI or AAI. They only really know how those measurements correspond to people who have much more severe injuries. So if you look at the Freeman-Katz study, It's the only one that actually looked at DMX findings in normal patients and those with chronic symptoms caused by a car crash. They looked at the probability of a blinded examiner correctly classifying patients into the normal or trauma groups. And if you had 2 or more abnormal findings, that was 93% sensitive and 79% specific. What does that mean? It just means that there was a higher odds that they would correctly classify you as traumatic. It also means that there's some wiggle room in there, right? That if you use these measurements, you have to understand that, for instance, if you use 4 millimeters of overhang on C1, C2, that there's still a 5% chance that's a normal finding, but a 95% chance it's an abnormal finding. So Larsen hasn't read this study, obviously, and he hasn't performed any blinded reading studies on any of his own measurements or theories regarding ultrasound and Doppler. So it's hard for him to criticize a study like this when he hasn't done his own research on what it is he considers abnormal. And it's also important to note that the surgeons in this area suffer from the same problem. They perform no similar studies on chronic CCI patients on CXA, Grab Oaks, BDI, BAI, translational BDI, translational BAI, etc. We don't have this same research on those findings. So here's a good example of how Larsen just doesn't really know what he doesn't know, and I wouldn't expect him to know this stuff. I mean, for God forbid, he's only had a personal training certificate, not any kind of formal medical education. So he points to this here showing 4 millimeters of overhang. Number one, it's probably not 4 millimeters of overhang. How can we measure that? Well, we know what this distance usually is, and we can superimpose that distance on that overhang. So in most patients, this is 10 or 11 millimeters. If we take that, we move it over here. You can see that if this is half of this is 5.5 millimeters, somewhere in there, then half of that is going to be 2.25 millimeters. So this is about 2 millimeters of overhang, not 4. But again, this is the kind of understanding I would expect from Larsen if he had gone to medical school, i.e., how do I deal with that measurement and how do I figure out what that probably is or isn't? It's definitely not 4 millimeters. In addition, he states that this is an abnormal Dmx overhang. It's not. And why is it not? Because these measurements up here are symmetrical, meaning the distance between the dens and the atlas is symmetrical. I'll show you over here. This distance here is equal to that distance there. So it's actually a normal variant rather than a likely abnormality. Because he didn't read the CATS paper and then didn't apply the fact that there was an asymmetry of the dens in the atlas to make sure that that was an abnormal finding. So these are our diagnostic criteria. I keep beating them in, day out when I'm online. One is a history that explains why the person has CCI, got bonked in the head, HEDS, etc. And that there's some imaging that seems to match, usually DMX, but sometimes we'll use other things. The symptoms generally need to match. The exam localizes to the upper neck. The patient needs to have failed conservative care and generally be considered a surgical candidate. Other diagnoses have been ruled out, things like dizziness coming from the inner ear, and there's been appropriate responses to treatment. All of that can help us get to a diagnosis where it's highly likely that we're dealing with symptomatic CCI. If we have fewer of these, then it's less likely that we're dealing with symptomatic CCI. So in summary, I think Larsen's ability to think outside the box and his general criticism that CCI is overdiagnosed, often on social media or in imaging alone, those are I think it's great that he's thinking outside the box. And I think, yes, it is overdiagnosed. And I have to tell you, I think this is a smart guy who now needs formal medical education, which it sounds like he's trying to get. So I can't really wait to see what this guy can produce with a formal medical education. So that's good. But in the meantime, because he lacks that formal medical education, there's some pretty big inaccuracies in the blog that need to be corrected. Hence, what we talked about today. So I apologize for that being a bit long in the tooth, but there was a lot in there, and I skipped over large parts of it to try to get to the meat of what the issues are with that blog. Okay, lots and lots of questions. Let me see if I can get to those questions now here, everybody. So what are your thoughts on lateral flexion X-ray versus the Dmx? Patient lateral flex as much as possible and good views of 212 lateral muscular capture. Can it make up for Dmx? I think, as I've said, I think we may be able to get there with a lateral open mouth view. The advantage of Dmx is that it involves the person moving and then stopping and going the other direction. And you don't have that on static imaging. Having said that, this may work for some people. Now, there's a bunch of things that have to be controlled for. The head's got to be perfectly straight, and you have to have the mouth open in such a way that you can see those corners. And the person has to be maximally laterally bent as far as they can possibly go. And yes, it's probably possible to make a diagnosis based on that. But again, it's going to suffer from not being as good as Dmx for the reasons I talked about. My report on lateral flexion X-ray says no evidence of rotator subluxation with lateral flexion, no lateral offset of lateral muscle with two respects is noted. Yeah, I'd have to see the images to know what it is they're talking about. I think, again, what they're looking for there is what Larsen talks about, right? The concept that if you've got something going on up here, the only possibility is that it's a major thing that needs emergency surgery. So I'd be very concerned that the radiologist wasn't really looking for what it is we want them to look for. John, if a ligament has gotten so loose, not torn to the point where it no longer makes a cracking noise like it did initially when loose, can it still be repaired with regenerative injections? You know, John, I'd need to see imaging. I'd need to do an exam to answer that question. In general, the cracking noises tend to come actually from crepitus or little air bubbles within the joint more so than instability. So for instance, when you crack your knuckles, you know, you're not generally unstable. You're able to do that from a young age. That's the buildup of those air bubbles. John, if a patient's patella pops in every time they flex and extend their knee, did it progressively loosen the MPFL? Did injury secondary to hypermobility? Can this be fixed with Prolo or PRP? In general, John, we've seen a lot of patients with that issue. We've treated a lot of patients with that issue and have helped a lot of patients with Prolo PRP. So yes, in general. It's been advanced by Oleg. Lymph nodes around my neck area, front, back, upper, lower, etc., become easily palpable over the years, not visible though, and more sensitive to increase a bit in size to things like insect bites, pimples. For a bit, can this relate to CCI, or is like from self-massaging the area due to CCI aches? You know, Oleg, I think you need to get qualified or checked out by a qualified head and neck or ENT doctor just to make sure you're not dealing with any kind of crazy cancer that could be in lymph nodes, etc. As far as could that be to do CCI, I haven't seen it frequently be associated with or in CCI patients. And it could be from self-massaging the area, but lymph nodes are kind of outside my area of expertise. Stacy. Yeah, believe me, there's some inflammatory things in that blog. I didn't cover all of them. But the one about, histrionic women was pretty interesting. McNasty Slam. I had prolotherapy a few days ago for CCI. It was the third treatment used dextrose solution. First two treatments were fine. I woke the next day with extreme headache in the back base of my skull. Yeah, I need a lot more information to know what it is they were injecting. Were they injecting blind? Were they injecting with guidance? What was the goal of the prolotherapy? What were they trying to inject, et cetera, et cetera. So hard for me to answer that kind of random question. Again, is it common for neck pin instability to cause breast pain? Ultrasound normal, but pain persists after trauma-induced CCI. Not really to cause breast pain. We certainly see instability in the anterior rib cage. And that can happen in hypermobile patients or in patients that have had direct trauma here. So that's probably the first thing I'd be looking for in that kind of history. Francis, I hope you don't mind these questions. Previously asked what should be better for intradiscal treatment, PRP or stem cells. The PRP works well for an annular tear, while bulges require stem cells culture and hypoxia. But for treating a mildly degenerative nucleus, I know you prefer to treat extradiscal structures first, but when that proves insufficient, would high-dose PRP or 5 million expanded MSCs be preferable? Be preferable. I'm not sure what you mean as far as preferable, meaning that depends on whether or not that's causing any problems, meaning that we have no research to date that shows that injecting stem cells or anything else inside a disc generally makes a new or better looking disc on MRI. In fact, every large clinical trial that's tried to do that has failed. I was the first person on earth to put stem cells in a disc back in 2005. And so I've got the world's largest experience on this. At the end of the day, every once in a while, you can see some improvements in discs on MRI if you've got mild degeneration by using orthobiologics like high-dose PRP or stem cells in the disc. But those are generally one-offs and not reliable. So as far as what I would prefer there, a lot would depend on what it is we're treating, meaning if you're trying to get the disc to look normal again, that's not going to happen with either one of those in general. It's been advanced by Oleg Chuchin. Any good physical therapist you recommend for EDS, CCI, and related issues in North Jersey area? What about knowledgeable personal trainers by any chance? Want to exercise, but I just don't want to exercise even good. Yeah, in general, you're not going to really have a lot of luck with personal trainers. It's kind of funny. This guy's a personal trainer, but that has nothing to do with it. Meaning in my experience, personal trainers don't have the education to know what to do or what not to do in injured people. So that's kind of the biggest issue there. As far as good physical therapists, yes, Carla has a list that we maintain. But if you really wanted to just go online and try to find somebody, the probably highest level spine physical therapist that I have seen, I'm going to try to look it up for you here. Okay, let me share that here. So this Institute of Physical Art, or if you look up IPA Physical Therapy, is a really good one. So IPA Physical Therapy, they've got a list here of providers that you can look up as well. And I think this is probably where I would start. So look up IPA Physical Therapy. Go to this website, look up providers, because they're really, these guys really are educated at a very different level, and they try to get their therapists to mastery, which is very, very different than a lot of physical therapists that you see in high volume practices where they're kind of, they're basically just one physical therapist supervising 2 or 3 physical therapy assistants treating, 6 or 7 patients, where it's nothing like what this is. So I would really look up these guys in your local area. McNasty, CT showed Atlas shifted forward. I flew home, went to ER. ER took CT and MRI with no issues found. Sent me home and said probably it's a small CSF leak that'll heal on its own. Could be, again, I'd have to know what it is they were trying to do. Were they using guidance, etc.? Is it possible that using blind prolotherapy, they could have gone too deep and punctured the dura out? That's possible for sure. They also could have injured an occipital nerve because, again, they're not seeing any of this stuff. And the concern there would be if they had injected prolotherapy solution intradural, meaning inside the dural space, which is what these guys were talking about at the ER, then that could have been a bad day for everybody, meaning the anesthetic in the prolotherapy could have made you, unable to breathe. That's called a high spinal. And the hypertonic dextrose solution could have injured the brain and or cerebellum. So if that's what happened, and I'm not saying it is, only it's one theory, then that would be truly a bad day for everybody. It sounds like you avoided something really bad if that's what happened here, if they caused the dural leak. Wes Porter, I've done upper cervical chiropractic for 15 months. It's been really awesome, but I'm still not holding well enough. So going to give Prolo a try. Yeah, Wes, I don't. So again, lots of things under that description of prolotherapy. What I wouldn't probably do is to try blind prolotherapy. See our conversation just above with McNasty. But if you can find a prolotherapist that'll do these supraspinous, interspinous ligaments under ultrasound guidance or X-ray, I think that may be worth a try for sure. Becky, Dr. C, I'm 7 months out from posteriors. They've definitely minimized C2 rotation, as evidenced by the visit with Dr. Rosa in June. I'm very grateful for that progress. When I walk for any distance, it seems like I get contraction and spasm to stay by physio. I saw back at the neck suboccipitals, if they use red light therapy, can settle things down. Anything I can do, or more specific injections. Yeah, so Becky, a couple different things. One would be obviously trying some gentle strengthening of the upper cervical muscles, because that may help overall. I always think it's a great idea to work on curvature and posture as well. And assuming all that's been done and you're not getting any place, then it's possible that someone may need to look to see if you need a PICL procedure from the front. Liam, I can tolerate moderate cardio and weight training well, stationary bike and machines, nothing heavy, not much stress on CNS. Doesn't flare up any neurological physical symptoms. Really, is it okay to keep exercising? Sure. Yeah, I think that's certainly okay. It's been advanced by Oleg. Since sometime in probably my early 20s, I've noticed I get physical sense of anxiety post-workout. It's even expanded to sports physical therapy like volleyball, hiking, can be treated with related to spinal issues. It's theoretically possible that there could be irritation of the vagus nerve due to exercise. I wouldn't put it the first thing on the list, meaning the first thing on the list obviously is to meet with a therapist and discuss all of those sorts of things. But assuming there's no other rational cause, then the next thing to do would be to look to see if upper cervical instability is irritating the vagus nerve. Becky, I walk with soft brace. Sure, Becky. Liam, can you treat a slap tear on the left shoulder at the same time as PICL? Yes, in general, but just to remember, I think as I always say, that we want to be a little careful to make sure that that person can tolerate things like treating other areas, meaning that I'd probably say that about 60% of our CCI patients can tolerate when we treat multiple areas. About 40% cannot tolerate having more than one thing treated at a time because of that central sensitization and being too sensitive to procedural-based care. It's been advanced by Harry Winston. I would send whoever is making that claim the case reports of CCI patients you've helped. Yeah, I mean, I just thought I'd bring it up. Listen, like I said, I don't have only criticism there. I think I've got some supportive things to say that Larsen is certainly thinking outside the box, which is great. He's certainly trying some rehab and postural work, which is great. But I do think he doesn't know what he doesn't know. As far as whether or not we need to make him a fan, probably not so interested in taking the time to do that at this point. Roger, what are your symptoms? What are the symptoms of compressed cranial nerve 9, glossopharyngeal? Basically, a lot of patients would report pain or other sensations at the back of the throat, difficulty swallowing. Those would be the main things that most people would feel. Sometimes numbness at the back of the throat, etc. So those are the things associated with cranial nerve 9. And doesn't mean that has to cause those things, however, though, meaning we see people with issues at the back of the throat because just beyond that are things like the longus capitis, which are in spasm. So it's not cranial nerve 9, it's longus capitis reacting to the instability. So, but those are the kinds of things you would have to think about that. John, if it is determined that weak upper neck muscles are causing heavy head that is putting downward pressure none on the C0C or maybe on the C0C1 joint? Would it be enough to strengthen the muscles, or a combo of shots and exercise? Yeah, John, I think you always want to try to deal with your posture and strengthening your neck first, and see if you could tolerate that. Obviously, if you can, then great, you continue down that road. If you can't, then you've got to get worked up for instability to see if that's there. What are your thoughts on eccentric exercises to strengthen tendons? Dr. Keith Bart, UC Davis, showed 4.5 MRI patient patellar tendon growing in size after the tendon-specific program. Well, we wouldn't want to have a patellar tendon grow in size, because that's called tendon hypertrophy, and that's actually an indication of the tendon being weaker, not stronger. We'd actually want to see the tendon get smaller and more dense. So that's an important thing to recognize, that when tendons get bigger, it's because they're weak, not because they're strong. As far as doing eccentric work, I think that's great. That's a good plan if you've got tendon problems. Liam, when would a diagnostic injection for headache workup be done when a patient comes for PICL? Is it done between the PICL draw and the PICL injections? No, Liam, we only do diagnostic headache workups when we are confused as to what may be causing the headache. What I mean by that is that, for the vast majority of patients with CCI who come for PICL, we can get rid of their headache. Of the responders, I'd say 70% had headaches to begin with of one type or another, and the vast majority of those go away or go down. Now, there are patients where we can't get rid of the headache, in which case we've got to then go back and perform a diagnostic workup like that. But realize that a diagnostic workup for headache can take a long time, and it's not usually a one-day thing. So if we go to the regenexx website here and we pull up you find this for you. So if we look at the list here of all the things that can cause headache, it's quite a long list. So we got the C0, C1 facet joint, the C1, C2 facet joint, C2-3 facet joint, greater occipital nerve, lesser occipital nerve, third occipital nerve at C2-3, third occipital nerve at posterior C2, superficial cervical plexus at the SCM, supraorbital and supratrochlear nerves, auricular temporal nerve, C2 dorsal root ganglion, C2-3 disc, spinopalatine ganglion, and many, many muscle trigger points. So going through that whole list takes weeks. It's definitely not something that can be done in a couple hours or one day, unless you get lucky, right? Unless you do a good exam and you're like, I think it's a 0-1 facet joint, and you go and block that and the headache goes away. You pat yourself on the back, because it's better to be lucky than good. Then, how much should movement be limited or not limited while ligaments are healing at CCJ from PICL? I don't restrict anyone's movement when they're healing from PICL. The problem with restricting motion is that you then get other problems caused by that. So for instance, if you use a collar to restrict motion, you then get weakness in the muscles, which makes things worse in the long run. So there's really not any rationale that I can find for limiting motion. Now, you wouldn't want to do things to piss it off, however, right? If you know that riding in a car without your cervical collar on will piss things off, then you obviously keep your cervical collar on while it's healing, that kind of stuff. Paige, I have grade 1 antrolisthesis at C2-3. Is it a common finding in the CCI patient group? Sure, Paige. So that means that C2 or 3, so C2 is usually forward of C3, and or it can go the other way if it's a posterior listhesis or retrolisthesis. Now, what's interesting is that one's less common. The amount of normal motion, based on a study done by Lynn back in the early 2010s, clearly showed that there's not a lot of normal motion that happens at C2-3. So anything more than 1 millimeter there is considered abnormal. That's different than 3-4, 4-5 in the lower joints, where you're looking at least 3 millimeters of translation, where you start to get concerned. So long story short is we do see that a lot in our CCI population. And in of itself, because C2-3 is responsible for balance and headaches and other things, it can cause issues all by itself. Diana, when I lie down to sleep my back now, I get severe headache from pressure of the back of my skull on the pillow. What is skull pain caused by? It's mainly alar laxity. Lastly, why do I loudly hear my own heartbeat in one ear while laying down? As far as hearing your heartbeat, that could be due to some particular issues with internal jugular vein compression, but it's also a common thing noticed by lots and lots of patients without CCI. As far as getting a headache from any pressure in the back of the head, that's probably irritation of the nerves that go back there, greater occipital nerve, lesser occipital nerve, C2 spinal nerve root, etc. Oleg, Dr. Centeno, some people have mentioned that during telemed, they barely got to ask questions. They had mentioned important points. This is a big step, complex issue, etc. I was under the impression the consult is 1 hour. So yeah, Oleg, we do 40 minutes for telemedicine and then 1 hour for new patients. So that's a lot of time to ask questions. Usually for most patients that are not super duper crazy complex, we have a good 20 minutes during telemedicine left to go over questions back and forth. And then there's another 20 minutes or so during an actual hands-on evaluation. So that's unprecedented amount of time with the doctor, I have to say, meaning that I don't know of any other physician practicing in this area that provides that amount of access. And then if the patient hasn't gotten their questions answered there, they're free to email me directly. Again, I don't know of any other doctor that does that. If you do, you let me know. So is it possible that we may have some patients, meaning 5% of the patients, that feel like they've got more questions than we've got time to answer? Sure, that's definitely possible. But those are unprecedented amounts of time direct one-on-one with the doctor, just like it's unprecedented for a doctor to sit down with you guys twice a week and spend an hour, hour and a half each time answering these questions. So hard for me to believe that there's a lot of people that aren't getting their questions answered. Certainly in my practice, from what I see. Now, is it possible that we have someone that is so complex and has so convoluted the clinical picture, meaning that we have 30 different imaging studies and there's information from no less than 20 other specialists, and they themselves have a pretty good anxiety issue going on? Absolutely, that's possible. And obviously, that's going to take away from that hour and 40 minutes between the telemedicine and time with the patient. But as far as people not getting most of their questions answered, I don't think that's a common thing based on what I have seen in my clinical practice. And then obviously, if they still do, they can email me, they can text me. I've been texting back and forth with the patient all morning. I answer on average 3 to 5 patient emails a day, sometimes as many as 10. And then obviously I do this twice a week to try to give everyone more chance to ask more questions. So I think there's ample exposure to the doctor to get questions answered. And if you can't get them answered in that type of format, then it's probably not we probably don't have the issue of not enough time. There may be other issues involved, but it doesn't seem like it's not enough time. Kristen, the muscles on my left hand side of my neck are very sore. Where's the best way to build them stronger during PICL? I know there's a fine line of exercise after PICL. Would you inject these muscles? Dr. Rosa thinks the pain in the side neck is more of a set issue. Kristen, I'd have to do an exam to answer your question. Those are the kind of things that are determined on hands-on exam. It doesn't look mostly like the facet joint or not, and in which case Dr. Rosa may be correct. If it's more just muscles, so for example, we've seen at the lateral aspect of the C1 spinous process or C1 transverse process, which you can feel kind of here, that's a common area for patients to have a lot of pain with CCI because the tendons that attach there, and we frequently treated that as well. What is the pulling sensation under neatly TH that many of us feel? Not sure what the location is there. So maybe, Kristen, if you can jump back in and tell me what that is. Oh, here we go. Where's the pulling sensation under the chin that many of us feel? Yeah, so if we look at what that could be, let's look at some pictures here. So there's a group of muscles called the strap muscles, and thyrohyoid, omohyoid, sternohyoid, etc. And in addition to those, you've got the sternocleidomastoid. But those muscles go up from here to the hyoid bone, and then you've got muscles that extend from the hyoid bone underneath the chin. Now, in a lot of CCI patients, we've seen that these anterior muscles get overused, and so consequently, they may pull. But they're pulling because the person is trying to use them to stabilize their head on their neck. And because of that, they're in spasm. So it's basically, they're just not designed to do that work. But the body recruits them because it's one of the mechanisms that it has to try to provide stabilization. Deanna, hi, Dr. Centeno. The question: after a set of x-rays 6 weeks ago, I am still flared up with increased wobbling, dizziness, skull pain, clicking throat. My head also feels twisted. So then can I explain it? My skull feels lopsided. Is something patients commonly say. Is my atlas rotated? Well, Deanna, I can't make that diagnosis online, but I can certainly say that if you had a set of x-rays where they're moving around a lot and that caused a lot of issues, that you may want to see an upper cervical chiropractor, NUCA, or AO, to see if you are out and whether a simple adjustment may help calm things down. We certainly see a lot of HEDS patients or really unstable patients where after a DMX or after certain x-rays, they will get thrown out, or even after being turned over after a procedure. And frequently we hear about them going to really qualified AO or NUCA docs and getting that put back in, and they feel pretty good. Link to the Larsen blog post. Yeah, I'll try to find it for you here in a little bit and see if I can put it or have Carol put it in the comments. Stacy, had my chiropractor who does CRA muscle testing test the new nerve plexus you streamed about. He'd never heard of it and was shocked to see that I pulsed at 1,000. That should be 0, so we adjusted it. I don't know what all that means, but if it helped, that's great. Ben, it's mostly luck of the draw if stem cells proliferate into tissue desired. So injecting a ligament, is it luck if it proliferates into ligamentous tissue versus just not doing anything, since stem cells are general contractors, but they do always have the next exact instructions to build what they needed. So Ben, when it comes to bone marrow concentrate, which contains your own mesenchymal stem cells, the way that works as far as differentiation is concerned, is that there's a number of cues the cells get. So one of those cues would be stretching. So for instance, if we put cells in culture and we add a stretching force to those cells, and in fact, one of the guys we worked with at CSU, John Kizaday, did his PhD at MIT on that issue. It's called Mechano Induction. They'll tend to become either muscles or ligaments depending on the amount of stretch. If you put pressure on them, high pressure, they tend to become bone. So one of the things that cells link into is those external pressure cues. Now, there's a whole other set of cues as well. There are chemical cues from the local environment. For instance, what am I sitting in? So for instance, if I'm in a matrix that's rich in calcium, I'm more likely to become bone. If I'm in a matrix that is rich in certain types of collagen with certain types of pressure, then I would become cartilage. If I'm in a mix surrounded by fibrous tissue, that I'm more likely to become ligament or tendon, those sorts of things. As far as luck of the draw, it's not luck of the draw. There's actually quite a bit of hard science published on this idea of how cells determine what it is they want to be when they grow up, or in this case, differentiate. Stacy, any knowledge what symptoms could be caused by retroflexadontoid with Pannus? Can retroflexadontoid be caused by trauma? Is just really the neck curve need to be corrected? Can odontoid end up where it belongs with the correct care? So retroflexadontoid is a fairly specific thing. So let's talk about that. The retroflexadontoid means that the odontoid or the C2 kind of goes backward. And this is actually a good one. Let me see if I can make that a little bit bigger for you guys, because that's not too big. Certainly not too big on my end, and I'm an old guy, so I got to see things big. Okay, here. So let me put that up there, and then we'll switch the share. Okay, so retroflexadontoid simply means that the odontoid goes backwards. And I'm actually going to try to, share the whole screen so I can write on this thing here. Apologize, let me do that a different way. Okay, so the odontoid is C2, right? So this is C3 here. This is part of C1. This is C2. Now, normally the odontoid kind of goes straight up like this. And odontoid in Latin means tooth. So it's a tooth-like process here. So it normally goes like that. And you can see this one goes backwards. This is the front here. And this is the back or posterior there. But this one goes backwards, and that's called the retroflexadontoid. Now, the problem with the retroflexadontoid is it's usually in that position because the person was born that way. So there's not much that can be done there about a retroflexadontoid. Now, sometimes is it possible to get maybe some trauma that causes it? It's possible. You can see here this little disc that didn't fully form. That's kind of vestigial. And that is something that could be injured. If that's larger in someone, that could have a ligamentous injury that moves it backwards. But for the most part, it's just person's just born that way. So the best we can do is stabilize things to reduce the problems there. Now, pannus is what forms at the back here, and it can be swelling that occurs, and so it puts more pressure on the brainstem. Pannus is usually formed due to the instability, having little to do with the retroflexadontoid. So that'll give you a sense of what it is we're talking about here. So bottom line is that if it's very retroflexed, it may just be that the patient was born that way. So there's really not a way to fix it like that without surgically removing it, which is a huge procedure. Francis, I'm researching Cell Surgical Network, which I'm conflicted about. I came across a Google search result, a link to an article of your blog titled, "This data from Cell Surgical Network doesn't add up, but the article had been deleted. Do you believe that CNS data collection is untrustworthy?" Francis, there certainly never did full publication the way that we did it here at regenexx. And what I mean by that is that Cell Surgical Network is a different beast. So when it came to us growing our regenexx network, we have very, very strict criteria as to who can get in the network. And that strict criteria has to be met or we bounce the person out. For Cell Surgical Network, it was a much broader blanket. So they took people in that had musculoskeletal knowledge, people that were urologists, people that were general surgeons, people that were ER docs, people that didn't really necessarily have a specific area of expertise, and they weren't limited to that expertise, meaning urologists could treat low back pain versus we would never allow that in the regenexx network, not in a million years. In fact, if I found a urologist, we wouldn't accept a urologist in the network to begin with, but let's say we had one and they were treating back pain, they'd get bounced out because it's not their area of expertise. Just like I would know nothing about treating erectile dysfunction. Hence, if I caught one of our guys treating erectile dysfunction, they would get bounced out of the network because that's practicing unethically, in my opinion, outside of your area of expertise. So Cell Surgical Network is not like that. and that may work for them. It doesn't work for us. As far as Cell Surgical Network and have they collected data like we have collected at regenexx and published that, in general, no, there hasn't been the same level of data collection. There hasn't been the same level of randomized controlled trials, publishing that data on what it is they do, etc. So maybe that's what I was talking about with that deleted blog post. I don't recall it specifically, but maybe that's what I was talking about. Stacy, if I have an avulsion at C6, does it mean a ligament has no place to attach? Certainly could. If you're talking about an avulsion in front at the ALL, I'm assuming, maybe, but I'd need to know more. Pia, do you know where specific facial cranial nerve can be compressed from AAI? It seemed to have happened to me with head movement looking to my right, my neck cracked on the left side, instant pain and then instant facial spasm lasting 10 minutes, only the left side of the face. What do you think happened? Where specific do you think the nerve got compressed? It could have been at the brainstem. So Pia, if this is just sort of a transient thing, I'm not sure I'd worry that much about it. If we look at where the facial nerve lives, let's pull up that. Just trying to find some good pictures for everybody so that everyone is able to see what it is we are discussing or talking about. This is actually not a bad one, and it looks pretty big. So let's see if you guys can see it. Okay, so this picture looks pretty nice in that it looks at where cranial nerve 7 comes off of the medulla here, and then it exits through these foramina, little holes, and then it goes forward. Now, depending on where it goes, whether it goes to the bottom part or the top part, it's exiting different holes. But basically, the area where the nerve goes into and gets threaded through parts of the skull, so that foramen is where we'd be talking about issues with CCI, where that nerve might get tweaked. Now, if it's a constant thing, then I think it's something you may need to get looked at. But if it happens just once, I'm not sure I'd worry too much about it. Meaning that if you've got HEDS, it's not uncommon for something like that to happen, or a cranial nerve here or there to get tweaked. Stacy, you're currently doing research as to why so many of us, whether prone or upright, seem to get worse as the day goes on. I think that's just more the muscle atrophy, Stacy, that happens with these issues. And one of our old physical therapists actually has done the most research on that of anyone in the world to date. That's going to be see if I can find his work for you. I always get his name spelled wrong, so you got his last name. Here we go. So Jim Elliott has done probably more research on that stuff than anyone else on Earth at this point. Basically, all of his studies talk about the fact that in upper or then whiplash or traumatic neck injuries, you can get atrophy of the upper cervical muscles. Those upper cervical muscles, once they get atrophied, are supposed to support the head, but that would cause, as the day goes on, more and more weakness because they're not really able to support the head on the neck. So that research has already been done. It's been done by one of our old physical therapists who used to work for us a long time ago. He then had this idea way back when. He then went and did an entire PhD thesis on it, got a PhD, and now works, I think, still at Northwestern. I'm hoping that's right. Let's see where Jim, see if that's right. J.M. Elliott. So let's see where Jim is at these days. Yeah, he's still at Northwestern in Chicago. But anyway, that research has already been done. Jim Elliott would be the world's expert on it. This Kjetil Larsen guy's YouTube channel, he thinks that all musculoskeletal complaints can be fixed with strengthening the muscles. YouTube channel is called MSK Neurology. Yeah, I saw that his website is called MSK Neurology. I've not taken the time to research his YouTube channel. Listen, at the end of the day, I would say that there's no harm to try exercise or postural-based therapy. And to the extent that he believes that he has found some sort of magic key that will help a lot of patients, that's great. That I would recommend that he publish on all of that and get that out to the world in general. In the meantime, we see a lot of patients that have been to a lot of smart physical therapists and crash and burn when they try to work on these things. So there's another component there. But again, I certainly applaud anyone who makes people think twice before they get big procedures. Oh, thank you, Stacy. Floyd, is it possible that some people become unstable due to muscle weakness developing and proper motor control of the muscles but still have good ligament integrity? Oh, sure. Yeah, Floyd, there's no doubt. There's probably a lot of people out there like that. That's one of the reasons why we would always recommend people doing active physical therapy, strengthening, postural work, all of that good stuff. And many of those patients kind of separate themselves out into two camps, right? You've got, so I'll give you a great example of that. We used to have this machine in the office, I think we still do, called a multi-cervical unit. It was a great little neck strengthening machine. And I would take some of our traumatic neck injury patients and I'd send them for this type of strengthening. It seemed like a reasonable thing to do. It was very scientific, little machine that measured each and every little head and neck movement, allow you to go to light weights if necessary, etc. Now, it's interesting that about half of the patients would do extremely well on this, and they would get stronger and stronger and stronger, and the other half of the patients would crash and burn, meaning it would make them much, much worse. So in general, I think that's what we see with this population, but even more magnified, meaning that these patients try really hard to do strengthening, but more often than not, they tend to crash and burn. Now, is it possible that's just bad strengthening? Sure. But in general, many of them have been through many different routes of physical therapy, postural exercises, etc., and they crash and burn. So it tells you that there's probably something else going on there that needs to be controlled for as to why they can't seem to strengthen like you and I would strengthen. Pia, do ligaments also need movements to be stretched to stay strong? Yes, absolutely. It's one of the reasons why I don't really believe in the concept of putting someone in a brace, because that's the same issue that we've been talking about, right? If you don't move, then the muscles will get weaker. If you do go ahead and move, then you may slow down healing a bit, but I think the ligament ends up stronger. And we see that in experimental evidence or experimental studies of animals. If they take an animal, they operate on a knee, for example, on some knee ligaments, and they try to immobilize the animal, which is really hard to do. Animals generally don't like being immobilized. The overall end result of the knee is much, much worse. If they actually let the animal do what it wants to do, which means they go down hard for 3 days to 7 days, and they don't really do a lot because they don't feel well, and then they slowly start to load that leg on their own, they get a much better repair. So I think we need to think about the same thing in healing these kinds of injuries. Robert, does scar tissue work against regenerative medicine? When I got injections, needle would crunch through each occipital injection. Yeah, so I think you're talking about a prolotherapy technique if they're crunching, because I know a lot of prolotherapists that want that crunch, which is very different than something like a PRP injection, for example. But scar tissue is disorganized tissue that gets laid down. Now, the good news is that with all ligament or tendon healing, you initially have disorganized tissue, And then over time, once it's loaded, that tissue tends to realign and go from scar tissue into healthy tissue. Now, you can certainly have patients that have too much inflammation that'll produce more scar tissue, or just patients that naturally will produce more scar tissue in general. Marcus, how would one know if muscle atrophy is causing CCI symptoms? I don't know that you'll ever know that it's causing or not causing CCI symptoms, but you can certainly see it on MRI. Not hard to see at all. Let's see. I wonder if we can find any open source Elliott papers here that will let us look at something without having to pay $40 or $50. Spine is an open source. I'm not seeing anyone. So anyway, I think I promised previously that we would start to look at some neck MRIs and try to help you identify this upper cervical atrophy that Elliott has now written about many, many times, and happy to do that. So I don't know that I'll be able to do it this Friday because I'm traveling, but maybe this coming Monday. Duck P, can you give your thoughts on a case report I can give link where the patient had chronic alar ligament injury, treated successfully with 3 months of hard collar use, MRI showed healed alar lesion? Sure, that's certainly possible. I think if you had an acute alar ligament injury and you tried to immobilize someone, it's possible it may heal. The biggest problem then is going to be you're going to be left then with pretty severe upper neck atrophy. And obviously that'll be dependent on age, right? If we're younger, we can tolerate longer immobilization and have less impact because of all the good things circulating around that help to keep our tissues young. So if you've noticed that a lot of young people don't really need to work out a lot, and they look great. But as we get older, we've got to really hit the gym hard if we want to look not nearly as good, but pretty good. Same thing here. So what was the age of the patient? How long was this diagnosed? How was it diagnosed? Meaning that did they use 1.5 Tesla coil MRI for a head coil and specific thin slices, or do they use something like an open MRI where you really wouldn't be able to see the alar ligament all that well to say that you successfully healed something? So again, you know, at the lay level seems interesting. At the expert level, a lot of questions. Ben, if a patient isn't responding to regenerative medicine, have you ever recommended they pursue surgery? Referring here to the ladder of treatment options from the CCI 101 book, stemming off today's presentation, patient being overoperated on, do you just mean operate on before trying regenerative injections first? Oh yeah, Ben. I mean, like I think like what we said on this channel is that there's a lot of patients out there who certainly may need to see a surgeon, meaning of the patients that we see, I would say that we're helping about 7 in 10 right now. And that still means that 3 out of 10 may get surgical referrals. So what I'm talking about is getting operated on before lots of other things have been tried. Or some of the over-aggressive surgeries like we see with cord detethering, or with major surgeries being launched on less information than we gather in order to make a CCI diagnosis. But definitely, there's some patients that do need surgery. So over-operation just means that they haven't tried everything first. So yeah, absolutely. Kristen, thanks, Kristen. Roger, yeah, Roger, that's the goal with all of this. Again, you know, when Oleg brought that up, I think it's important to recognize that we spend a lot of time with our patients. Again, a lot of time on telemedicine, a lot of time in the office. And then obviously, you know, every one of my patients has my email address. I text back and forth with my patients, et cetera, et cetera. And then obviously we do this to try to get lots of questions answered. And so that people can watch these at some later date, and one person's question turns into knowledge for another person. Sure, Kristen. Did you answer what you inject for a nerve block? So a nerve block generally for us is injecting 0.5% ropivacaine. We inject that because it's less toxic to the nerve than longer acting anesthetics like Marcaine or bupivacaine. Joe Henry, 26 days post PICL. My healing and stiffness are becoming less. I'm feeling good, but I do have a new symptom one side of my face and neck twitching multiple times a day. Could be muscle contractions during the healing process. You know, Joe Henry, I'd probably need to know more. I'd certainly encourage you to reach out to that doctor and get his take on that specifically. ALCAO nerve plexus. Yeah, I knew that's what we were talking about. Oh, Carol put the Larsen blog there. Great. Thank you, Carol. Zachariah, hi, Dr. C. I've heard many opinions that injecting C2 to T1 is generally safe, but C0, C2 is dangerous for the average prolotherapist. What are your thoughts? Yeah, prolotherapist, meaning if they're doing traditional prolotherapy, shouldn't go anywhere near C0 through C2 at all. Simply because they don't have the training to do that, nor do they have the tools, meaning that in order to inject C0, C1, or C1, C2 safely, you need serum fluoroscopy, you need training in how to do contrast confirmed intraarticular injection. You need additional training on looking at digital subtraction angiography results to make sure you're not injecting, for instance, in the vertebral artery, etc. So no, a prolotherapist who's doing sort of general ligament prolotherapy with minimal training shouldn't go anywhere near C0 through C2. Diana, theoretically, if someone does rupture their alar ligament, would their overhang be quite large? Would periodontal asymmetry tell us anything? I know you said rupture is rare, but I'm curious how this is seen on imaging. Yeah, Diana, I've looked at hundreds and hundreds of high field upper cervical MRIs, and I can count on maybe 2 fingers the number of times I've seen an absolute alar rupture that was very, very clear. Yes, they would have a lot of overhang for sure and a lot of periodontoid asymmetry, but this is a pretty rare thing even in patients with ongoing CCI. Let's see here. I think I've already answered that. And I've only got about 10 more minutes, guys, because I've got a 2:30 on my time frame here. Diana, is Pannus a factor affecting PICL outcomes? Don't know at this point. I thought it could be at once, so I did my own what I call home run versus strikeout analysis, and I couldn't convince myself that a Pannus was making a big difference, meaning we had patients who were doing well who had Pannuses, patients that were doing poorly who had Pannuses, and I couldn't convince that there was more Pannuses on the side of the people who were doing poorly. I can tell you that one of the things that we have seen is that in a patient with a bigger Pannus, before we started going above the atlas, we would frequently get into the dens bursa because it was quite swollen, and that would take, obviously, cells away from injecting into ligaments. Now that we have the dual C-arms and can more accurately inject above the atlas, it seems like if that happens when we're going below the atlas, that can be easily mitigated. Jeanette, what would a calcified ligament beam or calcified ligament mean? Catacomb beam. So Jeanette, it generally means that the body was unable to repair it, so it put bone there. It generally happens in older patients. So that's what a calcified ligament being or means. Avulsion of the spinous process C6, Stacy. Yeah, Stacy. So if it's absolutely avulsed off, then that's a potential problem. Now, you need to be a little careful by that because it's very hard to image C6 and the spinous processes, meaning it's pretty thin. So if you have something like 1 millimeter slices with a high field closed bore magnet, then I trust that. But without a high field closed bore magnet in 1 millimeter slices, it would be hard to make that diagnosis. Lindsay, if PRP failed at helping with disc tear and disc bulge, next step move on stem cells. Lindsay, I would need to know a lot more about what's going on with the disc tear and disc bulge. Is it causing symptoms? Lumbar, cervical, good disc height, poor disc height, et cetera, et cetera. Duct P, can a lax nuchal ligament cause the necessary pressure on 0, 1, and 1, 2 joints? Well, a lax nuchal ligament would cause a low CXA, and the head would tend to want to do that. So you probably wouldn't get any extra pressure. You might get different loading pressure on those joints. Robert, when will the general medical field learn more about migraine instead of what we were told it's a brain-mediated disorder and just toss out Aimovig? Yeah, migraine in medicine generally means a vascular origin headache. In my experience, it's pretty overdiagnosed, meaning that most of the time what we tend to see there are cervical headaches, and we're not really seeing true migraines. And then I've got just a few more minutes here before I've got to go to another meeting. So it seems like the questions continue to come hot and heavy here. Yes, the MCU-BT MCU was created by a physiotherapist, Denardis. He found that it helped some patients who complain of heavy head from chronic whiplash. Yeah, that was our experience as well. I mean, when it worked well. But when patients couldn't tolerate it, they crashed and burned hard. So that was one of my biggest concerns with it. Francis, there are several rationales for considering the stem cell black market or Latin America. Some patients' bone marrow does not produce the quantity or quality of MSCs required to meet treatment goals. Others may find allogeneic attractive because of apparent economic advantage. Will your licensed Cayman site ever incorporate adipose or allogeneic cells to bridge the gap? Probably not, Francis. There's just no rationale to do it. We got great results using the patient's own cells, so why take the additional risk of adding someone's cells into the mix? It seems like we're adding just an additional risk without adding much upside, meaning if we were having poor results with using the patient's cells, again, these rationales are kind of bullshit, to be honest with you. I hate to use that term, but as far as the stem cell black market, that is what that is. I obviously would not go to a clinic that's described as a black market clinic, whether it was for stem cells or for anything else, right? That sounds scary as hell to me. Black market, a black market medical procedure makes me think of the gal who got arrested for doing Brazilian butt lifts in a hotel room. As far as some patients, bone marrow not producing the quantity or quality of MSCs, we rarely see that. So it's really not a big thing other than maybe for marketing purposes. But as far as going to a black market, no, I don't want to go black market anything when it comes to medicine. Those are two terms you should not use together. Black market, medical procedure. Please don't put those together because that scares the bejesus out of me. Pia, do you think it would be possible to do a neck MRI laying on the side, trying to document and have vagus nerve compression possible laying on the side? No, I don't think that'll do it. If you're looking for something like vagus nerve compression, there is a technique called MRI or MR neurography. That would probably be the test to get. It's expensive to do. It usually costs about $3,000 or $4,000 to get one of those and then get it read by the appropriate people. But MR neurography might be something you would consider. Robert, you can look up Cerviguard, a CBP home advice for curve correction for those with severe reverse curve. Could this be used in conjunction with regen healing? Again, I don't think you necessarily need a tool initially. All you need, I've talked about this a bunch of times, is sort of a rolled up towel, put it behind the back of your neck, lie face up on it, mess with how thick you can do it. And if that dramatically improves your symptoms, then great. You might be a good candidate for curve restoration, but go to a curve restoration CBP expert before I try a home device. Judy, doctor went ahead and did PRP and hip osteoarthritis Wednesday. You expressed it wouldn't work. My pain isn't so bad to not try at least. Feedback appreciated. Yeah, Judy, I hope that works. It usually doesn't, but listen, I mean, usually doesn't mean that it won't always. So it's certainly worth a shot for sure to see if it's helpful for you. I am starting to run out of runway here for time. Beth, I'm sorry, HRH, what is the millimeter tipping point of overhang where the brainstem stops being irritated? Don't know what you mean by that. As far as what's considered abnormal would be 3 to 4 millimeters and above with an asymmetrical dens in the atlas. Beth had injection right thumb almost 10 years ago, still working. Oh yeah, thank you, Beth. That's great. Diana Clara, thank you for always caring so much on those questions. Sure, thank you, Diana. Dr. Postwick, Dmx clear shows my C6 avulsion. Yeah, you can't see an avulsion of a tendon on DMX. You can only see the bone, not the tendon. So that's something that would need some specific MRI or even a ultrasound. What would you say normal amount of time following spine surgery for patients typically need more? Orthopedist relative explained there's another luck of the draw for when more is needed. Yeah, that's called adjacent segment disease, and a lot of that would depend on how many levels you fuse. The more levels you fuse, the more adjacent segment disease you get. It depends on genetics of that person and obviously how active they are. So, for instance, if we're talking about an active 50-year-old where we fuse 3 segments and they want to go back and ski right away in the lumbar spine, you're going to be probably looking at ASD in most patients within the first couple of years. If that person doesn't go back to active skiing and they just want to sit at a desk all day and maybe work out a little bit on an elliptical, maybe you're going to add more time to that. And then we could have the same surgery in 2 different patients, one with bad genetics for ASD, one with good genetics for ASD, and you'll get different results. Okay, guys, well, that is about all I got as far as runway. That was, I think I got in about 5 minutes late, so we've been at this about an hour and 25 minutes. So thank you for all your great questions as usual. Again, the goal of this show, as much as I can do it, I won't be able to do it this Friday because I'm traveling to lecture, but I will be able to do it a week from today, is to try to get together, get these questions out there, get them answered, put them in a video format so you guys can go refer back to them so that by the time you do one of these procedures, you've got a pretty good idea of which end is up. So thank you for your time and energy and all your great questions, and I will see you a week from today. Thank you.